Dr. Jen McClelland. I'm the medical director at Frame, and I'm chatting with Dr. Sanders from IntelliHealth. If you want to introduce yourself.
Sure. Jen, it's a pleasure to be speaking with you today. I'm Dr. Catherine Saunders. I am co-founder of IntelliHealth, and I'm an obesity medicine physician. So we have many, many, many patients who are trying to get pregnant, are in different, phases of their journeys, and also seeing us for weight management.
Awesome. Awesome. I thought it would be really neat today to talk about the impact on obesity and fertility, and then also the impact of some of the new obesity medicines that are on the market now that are doing wonders and really are groundbreaking, but also could have implications on early pregnancy and how we should best be managing these patients, and how you can have conversations with your physician if you are thinking about these medications or you're on these medications and you're also thinking about maybe getting pregnant in the future.
Yeah, great questions that we discuss with our patients every day. So our patients who are overweight or have obesity are at higher risk for infertility, for difficulty conceiving, and then for pregnancy complications. So for us, when we see patients who are of reproductive age or trying to get pregnant, we always ask about their plans, if they're on contraception, their plans for getting pregnant. And this is part of our initial evaluation to really understand where people are in their fertility journey. Because yes, exactly as you said, when patients have overweight or obesity, it can be much harder to get pregnant. And so there's so many different considerations that, we need to think about in terms of what they're going through, what their plans are, how we manage them differently than our other patients, and just how to have these conversations. It can be very tricky.
Would you say that any of the medications that are currently on the market for obesity are safe in early pregnancy,
No.
or no? Yeah.
Definitely not. The short answer is no.
No. Yeah.
So none of the anti-obesity medications have been studied in patients who are pregnant. Because losing weight during pregnancy, you're more of an expert on this than I am,
Right.
it's obviously not something that we recommend. For people with overweight or obesity, there are certain guidelines about how much weight should be gained during pregnancy, and it depends on the pre-pregnancy weight or body mass index. But in no circumstances do we recommend that people lose weight during pregnancy. And in fact, these medications, since they have not been studied among patients who are pregnant, we just, don't know and should not be used. That being said, we do use some medications off label. So medications that have not been FDA approved for obesity treatment, but we use them to for people to lose weight and to prevent diabetes and for other indications. So for example, a good example is metformin. So
Right.
metformin is something that we use all the time for weight management, even in people who don't have diabetes or pre-diabetes or PCOS. But if they do have one of those conditions, then we would be more likely to use it. So metformin is something that is, we're more comfortable with people taking if they are trying to get pregnant, or if, they become pregnant, it's not, cause for an alarm. But that really is just the only exception here.
Right. Yeah. We used metformin relatively often, and obviously in PCOS patients, it was one we used a lot, and often we would even continue it in early pregnancy. So that one makes a lot of sense. I think one of the things that I've had patients come to me and ask, and we're seeing in the fertility world, is when should they stop the medications like Ozempic or Wegovy or Mounjaro or the new one Zepbound if they're thinking about getting pregnant? Is there a time frame that is ideal for them to be off of it before they try to conceive?
Yeah, so we have this conversation with patients who have plans to try to conceive, and we discuss kind of the risks and benefits. And, generally we'll stop a medication according to the half-life of the medication. So if it's a medication that's out of someone's system in, a week, then, we may stop it, a week or two before. But if it's a medication that really stays for longer, like some of the weekly medications, we may stop it 1 month before, 2 months before, 3 months before, and different providers are different. We don't have guidelines on this. But oftentimes, we'll stop a medication, at least one cycle before the cycle when someone is trying to conceive, and to be very conservative, sometimes, a little bit more than that.
Okay, that makes a lot of sense. I think what a lot of people don't realize is just how new some of these medications are, and that we really don't know the answer. I think that is probably the hardest part, is that there isn't a guideline that's out there. And so there's a lot of misinformation that's out there. And there's also just a lack of information.
Mhm.
So I think that that's really helpful to know that probably for these, they do last longer. Obviously, they have weekly injections. And so probably need to be off them a little bit longer than your traditional medicine that's out of your system in a couple of days.
Yeah, one medication that's really important to talk about that's FDA approved for obesity is the medication Qsymia.
Mm-hmm.
Qsymia has topiramate in it, and topiramate is a medication that is associated with birth defects. So among women who are on topiramate, which is half of the combo medication Qsymia, there have been reports of cleft palate abnormalities among women who were taking topiramate during the first trimester of pregnancy. So that's one medication that we are extremely, extremely careful about. Before we start a patient on Qsymia, we'll make sure that if she is of reproductive age, that she is taking birth control. And the medication actually has what's called a REMS, risk education mitigation strategy, to make sure that women are on birth control and not getting pregnant when they're on this medication, because that we know is what we call teratogenic. Compared to the other medications, we just don't know. But for topiramate or Qsymia, that is something that we take very seriously.
So, would you say that patients need to advocate for themselves if they are seeking some of these medications, and let their provider know that they might want to get pregnant in the future, or that they're not on birth control or contraception? Just because I feel like sometimes it does get missed. If you're not talking about it, people make assumptions, and we wouldn't, especially with a medication like that, want that to get missed in a patient. So they should probably let their provider know too, and not wait to be asked.
Yes, that is such an important point. Such an important point. So, we ask all of our patients during our initial evaluation, but right now it's a little bit of kind of like the Wild West in terms of weight management and what's going on these days. And there are many providers who are prescribing medications for weight who are not specifically trained in obesity medicine or weight management. And so people absolutely need to advocate for themselves. And before starting any medication for weight management, should absolutely discuss their plans for contraception or their current situation with contraception and any plans to try to conceive.
And I was going to ask you if you had seen, I know there's been some recent reports that, as far as contraception goes, especially with the GLP-1 drugs, that there is a risk that it's not going to be absorbed as well, because one of the ways that those drugs work is they slow down your gastric emptying. So the absorption is changed. And what I had read was we may need to shift these women off of oral contraceptives and move to methods that would be transdermal, like the patch, or like the NuvaRing, which is a vaginal ring, or even starting to think about an IUD or something else that isn't dependent on your GI system. Is that something that you're seeing too?
Yeah, it is. So we're cautious about this as well. Historically with the medications that were daily and the beginning of the weekly medications, we would see women have breakthrough bleeding.
Mhm.
And this is something that, is something that we take very seriously. So when we start patients on GLP-1 receptor agonists, and actually on, the newer medication tirzepatide,
Mhm.
it is a warning along with the medication that especially when women are first starting the medication and especially with each dose increase, what I'll often do, I won't change their contraception necessarily if they're happy with what they're currently doing, but recommend sort of backup birth control during those periods of time.
That makes a lot of sense. That makes a lot of sense. I think that's really important too. A lot of times people don't think about, what kind of birth control they're on and whether or not it works with all the other medications that they're taking. I know my patients would almost forget to say that they were on it because they had been on it for so long. It was just kind of a daily medication, almost to them like a vitamin or something else. And it would be me when I was renewing their prescription, like, oh, did you tell your primary care doc or did you tell your neurologist or whoever that you were on this? Because I'm not sure it actually works with the other things that you're taking. So remembering to say what you're taking is so, so important, especially like you said, I think we're seeing a lot of weight management not being dispensed by people that actually have training in weight management. And it is a little bit of the wild, wild west out here, both in-person clinics and virtual clinics. And really being mindful of who you're seeing. And then if you have a feeling that all the questions aren't being asked, advocating for yourself is just so important because of that. It's a little scary right now with how much is out there. Obviously, people like you are much needed and much in demand.
Yeah, it is a crazy situation. But yes, I think the main takeaway is that people really need to advocate for themselves. I'm also happy to talk about like any other topic related to, weight and fertility, like how we prepare people for
That'd be
um,
great.
trying to conceive and what happens. We often see a situation that's really frustrating where people stop medication in order to try to conceive, and then it ends up taking a lot longer than anticipated, and people regain while they're trying to conceive because it's a time when hormonal treatments for fertility, stress, there's so many different factors that can lead to weight gain while someone is trying to get pregnant, and especially if they've been on medication for weight and now they're off of that medication, they may be much more hungry, thinking about food more because their weight reduced and because they're off the medication. So this is a really tricky period of time where people are at very high risk for weight gain while trying to conceive. So this is a time when it's really important to optimize the way people are eating, to exercise as much as possible, and to really track. So if someone is not looking, they could gain 30 pounds and not even realize it. And so one of the most important strategies is literally just stepping on a scale. I'd say once a week or twice a week. Doesn't have to be every single day, but just so that you can identify early weight gain, like 3 pounds, 5 pounds before it's 10, 20, 30 pounds during this period of time.
And for those women that are trying, that are seeing that, and obviously they're off their weight management medications, do you think that maybe meeting with a nutritionist or having a strategy is a good idea for them?
100% strategy is absolutely necessary, and it should be part of the fertility plan, because if someone gains a significant amount of weight, then they can have pregnancy complications. And so knowing that this is such a high risk period for weight gain, really having a strategy for diet, exercise, weighing, even thinking about medication like metformin for appropriate candidates could be an option too.
Okay. Yeah. I know we saw a lot of patients, I'm in Texas and I had a lot of patients with PCOS and they would lose weight, whether through weight management medications or through a nutritionist and a diet and exercise plan. And they would then go to try to conceive, and they had gotten their cycles back. We do see cycle return when you lose weight with PCOS sometimes, and you see ovulation return. But then I would see sometimes what you're talking about, that they would start to creep back up, and then ovulation would go back to not being consistent. And it was very frustrating for them because they felt like, I can't be on the medication that I was on, and that's what was really helping me. And I never thought about having them step on a scale and really monitoring for that early weight gain. I think that's a really great idea.
Yeah. Yeah. So important to catch it early, and then change the strategy, or, have a, more intense strategy, to really counteract the weight gain during that period.
Right. I mean, and we definitely see it in our IVF patients, because they are on such high dose hormonal medications, which really do change your hunger pattern and your sleep patterns, which, we know can impact weight gain and stress levels. We see, that obviously go all over the place during that time. And I do think that that is a miss that is on all of us, that we aren't having them see somebody and talking about nutrition and talking about weight management, because I do know it adds to their overall stress level. It's already a stressful time, and then they gain 20, 30 pounds. And to speak to what you're saying, obviously we're seeing pregnancy complications on the rise in the United States. And a lot of the morbidity that we're seeing is related to obesity and some of the diseases that often follow obesity. Hypertension and diabetes. And we know that these women are just at greater risk all the way around for pregnancy complications. And it would be great to kind of nip it before it happens if we can.
Yeah, exactly. And it can happen to anybody, but especially people who have insulin resistance, meaning PCOS, prediabetes, diabetes, and women who already are overweight or already have obesity. These populations are at much higher risk. So it's very, very important for everybody to talk about, optimizing lifestyle interventions, diet, exercise, behavior, but especially people who are high risk.
Well, that's great advice. I think that would be really important for our patients to really think about how to manage it during that time. I think that's definitely something that I missed in my practice for sure, is thinking about the weight gain potential in that trying to conceive period when they are off all of their medications for weight management. I think that's really important and something that I hadn't thought about. So I appreciate you bringing that to light.
Yeah, of course.
Is there any other tidbit you want to share, or?
One other thing I'll add, this is probably a smaller subset of your population, but for any women who've had bariatric surgery, it's recommended that they wait 12 to 24 months before getting pregnant. So that's something that's important. Again, a small subset of your population, but for any woman who's had bariatric surgery, the recommendation is, 12 to 24 months.
And it's really important. I'm glad you brought that up, that they mention that to their obstetric provider, because if you've had bariatric surgery, we actually change your vitamin strategy, and we change some of your testing strategies, especially for gestational diabetes, because of that change in your gastric system. And, we definitely see patients not reveal it, and then their test results don't make sense, or we see some vitamin deficiencies as they move through pregnancy. And that's when we sort of uncover that has happened. So that's really important too. Mm-hmm. Awesome. Well, I really appreciate your time today, and hopefully we can have more chats about how this could impact fertility and all of those things.
Yeah, well, so happy to chat with you. This is such an important topic that isn't focused on enough. So happy to talk about it anytime.
Awesome. Thank you so much.
My pleasure. Bye.
Bye.